In Essential Task 9.4, we are going to discuss the major diagnostic categories of anxiety, obsessive-compulsive, and trauma-related disorders. Now, these are actually all separate categories, although we're going to group them together. So under the broad categorization of anxiety, obsessive-compulsive, and trauma, we're going to talk about a handful of anxiety disorders, which is the furthest to the left, the single obsessive-compulsive disorder for our purposes, OCD, and then one trauma-related, PTSD. I should note at the bottom, there is an understanding anxiety disorders box, similar to the understanding schizophrenia box that was on the Essential Task 9.2. So do leave some room at the very bottom. I will be honest, some students have used two pieces of paper for this concept map because they had a difficult time fitting the singular box here at the bottom, because although it's one box, it is a taller box. So if you find yourself facing that issue as well, feel free to do that. I will return now, though, to the task text, allow you to copy down the portion here in yellow. You don't have to worry about that blue italicized. That's just the list of the disorders from today. Just the portion in yellow. We will start, as we always do, furthest to the left, by talking about anxiety disorders. Anxiety disorders are a collection of disorders that are characterized by either persistent anxiety, a physiological response that I imagine many of us can relate to. It's something that in many ways you can feel, things like your heart rate increase and your respiratory rate increasing. Or, besides just experiencing persistent anxiety, we can also identify maladaptive or undesirable behaviors that are done in order to continually reduce perceived anxiety. And we'll see that when we talk about, for example, phobias. There are a few different disorders that fall into the anxiety disorder category for our purposes. There are going to be 5 major disorders in this individual category: generalized anxiety, panic disorder, agoraphobia, specific phobia, and then social anxiety. We'll start with generalized anxiety disorder. If an individual is clinically diagnosed with anxiety, just that singular word anxiety, that itself would not appear in the DSM. The actual diagnosis for quote-unquote anxiety would more than likely be generalized anxiety disorder. This is a categorization within anxiety disorders where the individual experiences an excessive amount of what you would anticipate, anxiety and worry, about a variety of topics, events, or activities. And what's really important with generalized anxiety disorder is that the worry does not really match proportionally the actual risk. So, for example, if you're worrying about whether or not your house is going to cave in one night, well, chances are, assuming the odds aren't indicating that that's likely to happen, then that's not really proportional to the risk. Now, if there's in the middle of an earthquake, that's a different story, but just generally out of the blue, worrying about your house burning down or something really catastrophic happening doesn't really match the proportional likelihood of those risks. The same could be true in school. If you worry about the worst case scenarios in school, whether that's in a social setting or taking an exam, and it's not really proportional to the actual likelihood, that might be the type of thing that we're looking for with a generalized anxiety disorder diagnosis. And what's important here is that these symptoms and sort of this list of worry is coupled with physiological anxiety. So this is a very physically based disorder, as all anxiety disorders are. It's normal to feel worried about certain topics. It's not normal to feel worried persistently the majority of the time for months on end, particularly when the worry does not really match the actual risk proportionally. Then we might look towards a generalized anxiety disorder diagnosis. The next are panic attacks or broadly panic disorder. The College Board could reference an individual panic attack, which might have a variety of physiological symptoms from hyperventilation to sweating to trembling, or they could, broadly denote panic disorder, which is, as the name suggests, unpredictable and persistent panic attacks. So not a one-off. It's actually quite common to have a singular panic attack at some point. When you have panic attacks in the context of, let's say, 3 months, and there are 4 or 5 of them, well, that might be a panic disorder. A panic attack in and of itself is an unpredictable, usually several minute-long episode of intense dread, and it has a variety of physiological markers, ones that we typically associate with arousal, but in the context of a panic attack, and they're typically unpredictable. They could happen seemingly out of the blue for no particular reason. I would like you to watch this clip here at the bottom so you see sort of an indication from the perspective of an individual who has experienced a panic attack, what that couple minutes is like. I like to transition from panic attacks to agoraphobia because sometimes the symptoms of agoraphobia might look like a panic attack if you don't make some subtle distinctions. So it's useful to compare these two side by side. Agoraphobia is a psychological disorder that is marked by a fear and avoidance of public open spaces, in some cases even crowded spaces, with the key caveat here of a situation in which one cannot easily escape. So what that essentially means is, if you feel like you're trapped, whether that's at the supermarket, and if anyone's ever gone to the supermarket during rush hour, it can be incredibly stressful for anyone. Well, an individual with agoraphobia would find that situation even worse because it's hard to escape. Sometimes you're in those aisles and you're shoulder to shoulder with people, and people are touching you and moving around you, trying to get a product, almost pushing you to the side, ignoring the fact that you're there. That situation can be very stressful. That can produce a lot of anxiety. Of course, this is an anxiety disorder. It could also just be public places where there's not an easy place to escape. So there are certain areas of my classroom, let's say right under the American flag, that might be challenging to just get up and move from if for one reason or another you felt uncomfortable and wanted to exit the classroom. It might be way more comfortable sitting closer to the door. So you always know, if I were to feel anxiety under the crowded situation that I'm in, I can easily escape. That might help alleviate some of this agoraphobia. You could theoretically see someone choose to stay home on a Friday night, not because they're shy, quote unquote, not because they're unwilling to communicate with other people, not because they get anxious and nervous talking to other people, because they simply choose to avoid crowded rooms. Oh, it's a party, there's going to be 50 people. I just don't want to go to a crowded area. I'm going to feel uncomfortable with that situation. That would be what you look for with the diagnosis of agoraphobia. As a mnemonic, I take the AGO in agoraphobia, and I think of the phrase, you can't ago in public. I do caution with that there are several disorders where being unwilling to go in public could theoretically be a byproduct of symptoms. It could be for shyness, for example, something that we're going to talk about at the end of our anxiety portion of this concept map. But nevertheless, unwillingness to go out in public is a clear indicator that we're looking at potentially agoraphobia, or at least agoraphobia and potentially a handful of other disorders. The last specific category, not to use the word specific here twice here, but the last category or column within the anxiety diagnosis category of the DSM is specific phobia, and then subsequent to that, we'll talk about social anxiety. Phobia is a term that you've likely heard quite frequently culturally. The College Board typically references as specific phobia. What that means is there is a specific stimuli or event, object, or situation that produces the symptoms. So you could have a specific phobia of spiders, of clowns, of talking in public, of certain situations. Specific phobias involve two things, and typically most students are pretty wary of the fear element. What students might not know prior to taking this class is that for something to be classified as a diagnosable phobia, it also requires avoidance. So we're looking for persistent irrational fear of spiders, and that and is very important, that's why it's bolded, persistent irrational avoidance of spiders before it actually rises to the level of a phobia. If you're afraid of spiders, but it doesn't really affect your life in any meaningful way, it's not really a phobia. Now, if you see a spider and you irrationally fear the spider, and then you irrationally avoid the spider by calling out of work for the next 2 weeks to avoid the possibility of encountering that same spider, well, yes, that's clearly to the level of an irrational avoidance. And as all psychological disorders require, going all the way back to the first box of this unit, that is affecting your life, in that case, in an occupational setting. I would like you to watch this clip to the bottom left corner. It's a clip of an individual who suffers from a phobia of pickles, and I think it's really fascinating to see the extent of this irrational fear and avoidance. Because the woman in that clip is clearly afraid of pickles, but she also goes out of her way to avoid pickles. And I think it's really fascinating to see that. The last one under the categorization of anxiety. So this is the last one that's explicitly an anxiety disorder before we transition into OCD and PTSD. And that is social anxiety disorder. If we took this class about a decade or so ago, this would have been called social phobia. The DSM has elected to revise the name, and now we call it social anxiety disorder. It is totally normal for many people to feel shy, whether that's in different situations or just generally a disposition of your personality. You are shy. Social anxiety disorders, when we take shyness and put it off the scale. So I have here the spectrum here at the bottom where we have, say, a talkative or extroverted, and then shy or introverted, reserved. Then there's social anxiety disorder way off the spectrum. This is an intense fear of social situations, typically social situations that require talking to new people, and thus a subsequent avoidance of those social situations. Which means we now technically have two disorders just today that could ultimately lead someone to decide to stay home on a Friday night. If you decide to stay home because you don't like crowded places, you don't mind talking to people, you just don't like crowded places, it's agoraphobia. If you cite the anxiety that you feel talking to strangers or being in social situations, well, then it's social anxiety and not agoraphobia. Notice how one clear behavior of staying home on a Friday night can be the byproduct of two separate disorders, and we do need to make clear distinguishing traits between the two and really identify those distinguishing traits so that we diagnose properly, because they might look similar from an untrained eye, but we're making those distinctions as we go. Proceeding onward into the remaining two columns, those last two of OCD and PTSD, technically these are divided in the DSM into their own categorization, so we'll give it the attention that it warrants and also do that as well. OCD, or obsessive compulsive disorder, is a disorder marked by repetitive and unwanted thoughts, which we call an obsession, and repetitive and unwanted actions, which we call compulsions. And typically it's the combination of both. The College Board over the years has almost exclusively referred to this concept in reference to cleaning, because it is a very common example of OCD. So for example, if you had an unwanted repetitive thought that the germs were just everywhere, that there's filth, there is germs, I cannot catch these things, germs are everywhere, and it is a persistent and repetitive thought that then leads to an action of washing your hands, let's say 50 times every time you leave your room, or choosing not to go out and touch, let's say, tables in public. Well, those actions that you're carrying out, unwillingness to touch surfaces or the need to wash your hands 50 times, are clear actions related to that obsession, which we call compulsions. Do note, I know I have them in parentheses, but obsession and compulsion could be identified individually on the AP exam outside of obsessive compulsive disorder. You could see a question that asks, what is an obsession or what is a compulsion? So that portion of the definition is useful here. I will note the other example I see on the AP exam. Let's say every night you need to check every doorknob and every window in the house 20 times to ensure that they're closed and locked. Well, that obsession, I need to check the doorknobs, I need to check the windows, would then lead to the compulsion of actually checking those areas. That would be another indicator of OCD, where there's this unwanted, repetitive thought, I have to check to make sure everything is locked, I have to check to make sure everything is locked, that then leads to some type of action, checking each of those locations. So those are the two ways I've seen OCD referenced on the AP exam. The last category is another disorder that you may have heard of prior to taking this class, and that is PTSD, or post-traumatic stress disorder. PTSD, as you might imagine, typically occurs in the aftermath of some type of traumatic event. So we're talking about things like going to a war zone or a natural disaster or some type of assault or a car accident. PTSD is marked by a variety of symptoms. There's sort of a lot of possible symptoms, so I've listed a handful. This isn't the totality of symptoms, but I think this is a good enough background in order to answer the questions that you could see on the AP exam. But this can involve everything from haunting memories to nightmares to social withdrawal, jumpiness, numbness of feelings, could extend into sleeping disturbances. The key, though, to PTSD and when diagnosing PTSD is that the symptoms need to last for 4 or more weeks after the traumatic experience. The reason that is important is you might have something traumatic happen, let's say a natural disaster, and for a couple days after, these symptoms might be pretty common. 2 days after a episode, though, you're not really at a point of using the word PTSD. You're in that window of time where it might actually be quite typical for you and others who experience that traumatic event to feel that way. Now, if it lingers for a month, it's basically the 4-week window, that month plus, well, then yes. And if it's then at that point, of course, as all disorders need to, disturbing you at school, at work, socially, well, then yes, absolutely. Now we're looking at a PTSD diagnosis. So it is important to note that these responses and symptoms are very natural in the aftermath of something traumatic. But if it lingers on beyond the 4 weeks, then yes, we might be confident about a PTSD diagnosis. The last element of today, and this is what I referenced earlier as a possible portion to put on a different piece of paper. If you can fit it, absolutely do so, though, is to talk about some of the possible explanations for what causes anxiety disorders, obsessive compulsive disorder, and then PTSD. Several of them, the entire left region of this table actually references back to our unit on behavioral psychology. Behavioral psychology is a term that we use for the theories related to learning. Back in that unit, we had classical conditioning, which was the flowchart. operant learning, which was the punishment reward system. We had observational learning. We also had a few other, but within that unit, there were 3 major types of learning that actually can explain anxiety disorders fairly well. For example, if you remember back to baby Albert clearly was conditioned to fear rats. One of the best explanations for the development of a phobia specifically is the classical conditioning flowchart. Maybe one day, clowns were neutral in your life, and then you happen to pair clowns with a really traumatic birthday event. Let's say something really bad happened at your birthday. You got embarrassed, something happened, you tipped over your cake, it was really traumatic. Let's say you associate that traumatic birthday with clowns because you happen to hire a bunch of clowns for your birthday. Now the anxiety and fear that you exhibit in the presence of a clown is a brand new conditioned response as a byproduct of the classical conditioning flowchart. That flowchart does a fantastic job explaining the development of specifically phobias. Additionally, let's continue talking about phobias. Let's say in the aftermath of that, every time you see a clown, you feel anxious because it's an automatic conditioned response. What are you theoretically and logically going to do? You're going to walk away from the clown, leave the room, go somewhere else. The moment you exit the room where the clown was present, your anxiety is going to begin to go away. As we talked about back in the behavioral psychology unit, when you get rid of something undesirable from your environment, like your anxiety, that's actually rewarding. Every time you avoid clowns or remove yourself from clowns when they start to trigger your anxiety, you're actually negatively reinforcing yourself. As is the case with all forms of reinforcement, it's going to produce this continuing behavior. So, for example, you develop a phobia of clowns through classical conditioning. The next time you see a clown, you feel anxious. What do? You go to a different room. What happens? Your anxiety goes away. That's a reward, negative reinforcement. 2 weeks later, you see a clown. What are you going to do? Go to a different room. Why? The last time you did that, it got rid of your anxiety. What's going to happen the second time? Your anxiety is going to go away. You got negatively reinforced again. And then every single time you see clowns, you continually negatively reinforce yourself by constantly avoiding the clowns. This is a cycle or a behavioral pattern that we're actually going to want to change if we were to treat phobias, which we'll talk about way later on in the treatment portion of this unit. The third is observational learning. You could theoretically observe an individual in your environment, for example, avoid snakes or avoid clowns, and then imitate that behavior. Observational learning was all based on observation and imitation. So you could theoretically develop fear of snakes or clowns or spiders because you've observed and then subsequently imitated perhaps your parents or your brothers or sisters or siblings or family members in general. The right side of this is to talk about some of the biological explanations for anxiety disorders. The first is to acknowledge that there are some fears that are more likely to occur than others. So I asked you a few moments ago to watch a clip of a woman who developed a phobia of pickles. Pickles innately are not that dangerous. It's unlikely that you would develop a phobia of pickles. Now, granted, it's possible, as you saw, but it's not likely. You are way, way, way more likely to develop a legitimate diagnosable phobia of snakes and spiders and heights, because those are either scary and innately dangerous situations, heights, or innately dangerous animals like a snake. And humans seem biologically predisposed to develop phobias for things that are more legitimately fearful and risky. So from the evolutionary psychologist's perspective, to connect back to the heading here, evolutionary psychologists always argue that our behavior is a reflection of the human's ability to constantly adapt in order to survive longer and longer. Well, if humans through evolution have developed this predisposition to fear snakes, that has, in theory, over the long-term human history, kept us away from snakes, which hopefully keeps humans alive and able to reproduce and pass on our genes so that continually in the future we'll avoid snakes. Speaking of genetics, twin studies show that anxiety disorders definitely have a moderate degree of heritability. It's not off the charts like schizophrenia, but in some cases it's about 25%. Depending on the study, depending on the numbers that you're looking, anywhere from the mid-teens up to the mid-20s. Just to indicate what these two abbreviations mean, because we haven't used these abbreviations throughout the year. MZ stands for identical twins, monozygotic, one zygote. So that's an identical twin. The D stands for dizygotic or fraternal twins. Identical twins are closer genetic similarity to one another. Identical genetic similarity. As a result, when we look at the column here that I have my mouse over, we do see higher numbers relative to the one to the right. That's because the individuals in this column are identical twins. We see that when we're looking at anxiety disorders, which is what this chart summarizes, we see that those numbers are higher, suggesting that there is, in fact, some degree of heritability when talking about genetics, that it does, in fact, run in the family. Not quite off the charts like schizophrenia, but definitely some modest numbers.